Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's live discussion on a very important topic. Let me tell you the topic for today's webinar, that is asthma attack versus COPD flare up, tailoring acute care in the ER. So for this topic, we have very eminent speaker. He is none other than Dr. Nitin Abhyankar sir. And let me share some of the achievement of sir. Sir has done MBBS, MD in internal medicine, European diploma in adult respiratory medicine, consultant pulmonologist and head of department of pulmonary medicine, Pune Hospital and Research Center, Pune. Course coordinator respiratory therapy, Pune Hospital and Research Center, Pune, and founder and director of School of Interventional Pulmonology. So, by taking not much time, I would like to invite Sir and hand over this session to Sir. Sir, the stage is yours. You can proceed from here.
Yeah, thank you very much and welcome all these World Asthma Day. And today we are celebrating World Asthma Day. So we'll talk about the flare-ups in both asthma and COPD. My slide set will run through the acute severe asthma, but I will keep on giving you commentary about what is the difference between the two subsets of each other. So what is asthma exacerbation? It's an episode of a progressive increase in shortness of breath, cough, wheezing, or chest tightness, or combination of any of these symptoms. So the asthmatic suddenly gets very tight spasm, and he can land up into the hospital or even an ICU or even a ventilation. One of the first things we should do with this is considering these three or four things. And sorry, so this is a question sort of for you, just to sort of stimulate your thinking. Will I give rapid fluid rehydration? Can I use mucolytics? Should I be using sedatives because the patient is very anxious? And can I use antibiotics? And we'll see. I'm not going to be taking a poll here, but the therapies which are not recommended for treating an asthma attack will include, firstly, strictly avoid sedatives, which will also be true for a COPD exacerbation. Sometimes the mucolytic drugs, which are like N-acetylcysteine nebulized, if they are nebulized in the emergency, they may worsen the cough and the obstruction, and therefore they are also to be avoided. But sedatives to be very strictly avoided. Chest physiotherapy may increase the patient discomfort, which will be there. So I think that is something. Hydration with extremely large fluids is not generally necessary, but optimized increase in the fluid, particularly in children and infants, uh, may be of help, because that will help dissipating the small amount of mucus plugs which may be troublesome to the very tiny ones. And antibiotics normally not recommended in these attacks, but exactly on the contrary, COPD people are often colonized with various microbiota, which may include things like E. coli, they can include like Pseudomonas aeruginosa, Klebsiella. So often antibiotics are to be prescribed as one of the first choices in patients who are on having COPD rather than asthma. So let's move on. Now, here is a case-based. This is a 51-year-old female, married one, known asthmatic for many years with seasonal worsening. Typical August September pattern that she was she was and started on salmeterol, which was the story at that point in time. She defaulted, went back to salbutamol nebulization on as and when needed basis, and that is what many of the asthmatics even today are doing. They resort to short-acting beta-2 agonists, and then developed a severe exacerbation, which is not that surprising. So, what would you do if you are involved as a visiting doctor in this kind of a situation? You are having a person who has defaulted on the drugs. What will be your first choice? I'm assuming there are some certain general practitioners, old timers, who may in the you in. So, would you consider injecting dexamethasone and daraphyllin? Injecting dexamethasone and daraphyllin, is that a good choice? Continuing salbutamol nebulization and give a steroid bolus, will that be good enough? Give a subcutaneous or an IV adrenaline, because this is an acute severe asthma, or start IV aminophylline, and which of these will be the right choices to be taken? And of course, try and assess how severe is the exacerbation, and also arrange to go to the transport to this patient to an emergency room. So I think possibly one of the most important messages is, yes, you can give a little bit of a nebulized salbutamol if you have it. You might even add ipratropium in an acute asthma attack. That's not a problem. None of the other things may be all that relevant or all that helpful, because even if I say injectable steroid will take 5 to 6 hours to act. So I think, and IV aminophylline is a very poor drug as a bronchodilator. Subcut or IV adrenaline cannot be given in a home situation unless you are driving a known anaphylaxis. So one has to think of moving this patient quickly to the emergency room. And what we do is assess them quickly, look how breathless is the patient, is he wheezing, almost inaudible wheeze, is there more ominous sign, is the person using accessory muscles, more ominous sign, suprasternal retraction, more ominous sign, and of course unable to lie down, sleeping is impossible for such patients. PFR, if you have a PFR at your hand, it is less than 80% of the personal best of the predicted, will be a additional tool. Inhaled rapid acting beta 2 agonists in adequate doses are essential. So you should give them either even in the inhalable form and through an inhaler with a spacer, or if oral bronchodilators can be given once in a while, but the rapid acting beta 2 agonist plus minus ipratropium. You give ipratropium, it is available. It is a good safe drug and can be given up to 6 hours. So then after you started whatever you wanted to do with this patient, if the patient shows a very good response, you might then give a steroid bolus, put the patient on a ICS and a LABA combination eventually, and give a course of oral steroids. If you think there is a bacterial infection, give antibiotics and move on with it. And there is a good response, incomplete response, or a poor response. Of course, even if for an incomplete response, move to the hospital will be the best idea. Only if there is a good acting response, then within the first 2 to 3 treatments in 1 hour. So every 20 minutes you keep giving one, and that is what BTS recommends. And patients with high related asthma related deaths, you should contact the physician promptly after the initial treatment. So this is of course meant for the family physicians or general practitioners of you. Which of the one following groups is not at high risk for a near fatal asthma? Patient who is needing 3 or more drugs to control the asthma. So, for example, patient needs salbutamol, formoterol, budesonide, and tiotropium, and needs a little bit of theophylline. Will he be at a high risk? He will be at a high risk. Patient consuming more than 2 canisters of inhaled salbutamol in a month. So he's taking inhalers. He's taking 120, 122, 140 doses in a month. That will be too much. So I think one has to think of moving such a patient. Patient consuming more than 10 canisters of inhaled budesonide per year. We'll come to that to the last. And patient who needed intubation for asthma 11 months ago. So within the last 1 year. So the category number 1, 2, and 4 all are at a risk of high risk of a near fatal asthma, whereas somebody who is regularly taking budesonide inhaled in a correct dose in an appropriate fashion and has been stable over last 1 year is almost unlikely, almost surely unlikely to get a near fatal asthma. You'll get an asthma exacerbation, but it will not go into that zone of fatal or near fatal asthma. So the other patients who are at this kind of a risk include history of a near fatal asthma, hospitalization or emergency visit for asthma within the past year, or a prior intubation for asthma, current use of or a recent withdrawal from oral steroids. That will be again, somebody who was on say 20 milligrams, 30 milligrams, all of a sudden you take it off, you may actually land up. Of course, I hope in today's scenario, nobody's on that higher dose of oral steroid and then you suddenly withdraw it. Over dependence on rapid acting beta 2 agonists. One of my patients used to carry, he was from Dubai, for 9 years he was doing to and fro, and before he came to me, he used to carry backfuls of beta 2 agonists. So salbutamol was the only thing that was with him, and he was using something like 4 to 5 inhalers per week, and that for 4 to 5 inhalers per month. So that will be a crazy amount of things. So somebody who's using too many bronchodilators are at risk. History of course, psychosocial problem or denial for asthma. Many patients are just not ready to the idea that they have serious asthma, and they are not, therefore not taking treatment. They are again at high risk of asthma related deaths. Of course, non-compliance with asthma medications, as we already discussed, and a very, very severe disease which is already poorly controlled will be also at risk. Suppose if you have a good symptom response at the end of 4 hours, the PFR is greater than 80%, then what would be our actions? May continue beta 2 agonist for next every 3 to 4 hours for about a day, then gradually reduce to even 6 hours every 6 hourly, and contact the physician and take the instructions for oral corticosteroids and discuss whether there is an infection or not. You might do a WBC counts and so on and so forth. What is in sharp contrast with this in COPD? You give beta 2 agonists. You may give short acting or a long acting beta 2 agonist depending on the situation. You may use nebulizations. You will use oral steroids, but you will invariably add antibiotics. So that is the main differentiating feature. And that antibiotics should be dependent on the local antibiogram. Now, here is the other situation with asthma where the symptoms decrease but return in less than 3 hours after the initial beta 2 agonist. If PFR is somewhere in the middle, it's not yet great, you will add an oral corticosteroid, add inhaled anticholinergic if that is what is needed. We talked about ipratropium is an excellent choice. So 4 times ipratropium, 4 times, yes. So you have what is maybe if you want to use a brand name, it may be something like Diolan. So the combination of ipratropium and levosalbutamol may be a good choice. So the beta 2 agonist also gets continued in that sense. And once again, talk to your physician who is looking for, who can give you the guidelines as to what to do, which antibiotic you want to add, and how much dose of oral steroids is appropriate in a given situation. In a diabetic, you have to be careful because you suddenly give them, say, maybe 40 milligrams of steroids, and their diabetes goes through the roof, and then eventually they catch up with secondary infection. Of course, the last but not the least and the worst of them, very small percentage of people will actually move from this to poor response zone. And the poor response zone is symptoms persist or worsen despite the initial beta 2 agonist. You remember me, once again, let me remind you, we have given 2 puffs of beta 2 agonist with a spacer. So salbutamol or Diolan, 2 puffs every 20 minutes for 1 hour. And things are not getting better, PFR remains below 60%, then of course add an oral glucocorticosteroid. If you have access, give an IV a glucocorticosteroid, but don't expect it to act immediately. So keep on repeating beta 2 agonist and keep on repeating it near continuously till you move to the hospital. You, of course, ipratropium should be added in this kind of situation, and immediately transport the patient to hospital emergency department. That is going to be. There are 2 types of asthma, and one of them is a very brittle one who shows more than 40% variability in their PEFRs over 50% of the time of the period, more than 150 days of the year, despite intensive therapy. That means these people you don't know when they are going to get into exacerbation. Somebody whose records say maybe 210 in the morning and records 400 in the evening, this is not a stable guy, and this is happening 150 times a year. That's problem. The second one, which is very difficult to pick up, is develops a sudden severe attack on a background of an apparently well-controlled asthma, and sometimes it is impossible to differentiate between these two unless until you are doing regular peak flow diaries. My patients do regular peak flow diaries all their year, and therefore I know which of my patients are brittle, which of my patients are unexpected exacerbations once in a while if they come across. Now, I'm asking a question again to ourselves. Most relevant parameter in deciding once you receive this kind of a patient with a casualty is what? Is it a partial pressure of oxygen? So oxygenation is more important. Is it just the saturation that is more important? Is it the partial pressure of carbon dioxide? Is he retaining carbon dioxide or not? And is it the respiratory rate? And now let's see what the answers to that kind of situation and a pH. And I'll try and compare this action program with the COPD exacerbation as well. So what is more important in what scenario? And increased carbon dioxide is almost a pathognomonic sign of a near fatal asthma, because this is a situation where you'll almost invariably have to intubate. Whereas, take example of a COPD exacerbation, what you are getting there is often a PCO2 is 50-55 and the patient is comfortable and wide awake and he's not going to be going into cardiac arrest. Whereas an asthmatic who's otherwise believed to be absolutely normocapnic, has no carbon dioxide retention, gets even 45-50, I'll be really worried. So he might be requiring a mechanical ventilation. and that is possibly the most important situation. So a very, very low peak flow, less than 33%. That's not true for COPD. COPD can often have PFR of 25% and still may be very stable. The saturation less than 92%, even less than 90%. Again, in terms of a COPD exacerbation, a saturation of even 88 is acceptable. Whereas in asthma, I would expect more than 92, preferably 95, 96, and then I will consider it safe. A PO2 less than 55, hypoxia can be taking us towards a near life-threatening asthma, and a normal or normalized PCO2. That what it means is it is increasing. So even if I see 41, 42, it seems apparently normal, but it is not truly normal. I have to go all out to get this patient on either an NIV support or intubate him if it is really life threatening, and a completely silent chest. Don't be very happy when there are no audible wheezes at all, because if the patient is gasping and he is not having such a tight spasm, he will not show you those typical rhonchi that you're looking for. Absolutely silent chest is an ominous sign. Of course, somebody with asthma should never be cyanosed. If it's cyanosed, it is nearly a sign of pain. And again, once again, feeble respiratory reports, efforts, and somebody with a lot of tachycardia. Generally, asthmatics would not go to more than 110. COPDs being elderly, often they are into 120s and 130s, and still they can be stabilized with supportive care, and they need not be intubated. Asthmatic, more than 25 breaths per minute will be a candidate to be considered for intubation, whereas COPDs often are breathing at more than that rate and often may not be requiring intubation or here. Increasing wheeze, increasing breathlessness, patient unable to complete sentences one breath, or unable to get up from the chair of the bed, either of the situations will be a candidate for to be considering upgrading the therapy to some kind of if I have a pulsus paradoxus, if I have that much of patience of measuring the drop in the pulse rate with inspiration to more than 10 millimeter of mercury, which I doubt whether we are able to do that unless until you are an ICU kind of a scenario. So if I have we are talking of prognosis of an acute severe asthma attack, and best decided by what? Best decided by the saturation on arrival. He's 94, 95, he's going to make it. His PFR on arrival, say more than 50%, he's going to make it. Respiratory rate on arrival, or pulsus paradoxus on arrival, or saturation after adequate oxygen supplementation. And the answer is, if the incomplete the baseline pulse oximetry, connect the pulse oximeter. If the baseline saturation is less than 92% in an asthmatic, otherwise normal lung, then this indicates a poor prognosis. This person, watch carefully, be ready to intubate, be ready with your NIV, whatever you are doing, and do it early on. After recording the saturation, start oxygen, and then start a nebulizer or a spacer. So don't go in the sequence of first nebulizing, then looking at the saturation, because often nebulizers also come with oxygen. So you would not know whether this person is at a poor prognosis or not, because you're not just not taken a few seconds to look at the baseline pulse oximeter. So I think that is very, very important. In our case, the ambulance and the ICU duty doctors, this particular case we started with, and the emergency paramedics reached the patient's home. She was found in a supine posture, almost gasping, and the pulse oximetry reading was 70%. And then they were struggling to start the oxygen. Patient went into respiratory arrest. So even before anything could be done, the patient went into respiratory arrest. Obviously, now this is called as a near fatal attack or a life-threatening attack. This patient, of course, deserved an ICU admission, and a severe attack persisting after initial asthma also will require. And if you are not worried about, you are not confident about whether the patient will comply with whatever your advice is, at least hospitalize the patient and keep him there for a few days. And previous near fatal or brittle attack, all these will be criteria for hospital admission. Somebody living alone, also don't leave him alone. Somebody with psychological problems, also don't leave him alone. Somebody with a physical disability or learning difficulty, also some of your autistic people, they might find it difficult to take those inhalation therapy correctly, and therefore they also will be there. And of course, pregnancy, it's a precious situation, 2 lives are at stake, so it is better to move such a patient to the hospital at least. And somebody in the middle of the night has an attack, preferably don't sleep on it. move him to the hospital. That is a safer game, better game. Any day, it's a much better game to play rather than any of those other situations. So the dictum should be somebody comes at 2 a.m. with whatever mildest of the symptoms, keep him overnight. Think of a discharge tomorrow morning after everything is stabilized. So in the hospital-based management, you'll look at everything. Look at the history, physical examination, whether he's using accessory muscles, heart rate, respiratory rate, PFR, if possible, FEV1, oxygen saturation, and ABG, of course, I mean, arterial blood gas. So all these will be done, and then you start up, look at the whole story and say, is this mild, moderate, severe kind of a thing? So if I have somebody who is dyspnea only on walking versus dyspnea at rest, dyspnea at rest is problematic. Somebody who is talking full sentences, giving you a big history, or something saying, no, yes, no, and sometimes words or sometimes even monosyllables. Watch out for that guy. Alertness, somebody very alert, no problem. Somebody drowsy or confused is a problem. With asthma, this is drowsy and confused is almost a very serious note. As compared to that, somebody with a CO2 retention with COPD, maybe even 80, 85, 90, but you give appropriate support, you oxygenate, and you can give non-invasive ventilation for a little while, and they will become alert again. Whereas somebody with an asthma gets into this kind of a zone, please be sure drowsy and confused, and somebody who is having paradoxical breathing is somebody who is about to arrest. Think of intubation. At least start initiate NIV if you think that is what is available to you at this point in time. And a bad accessory muscle use or a thoracoabdominal movement, absence of wheeze, and terminal bradycardia again are very bad signs. I told you very poor asthmatics usually don't have a severe tachycardia, but somebody is going into 40s and 50s, he is not to be considered. Please consider intubation immediately. That is around the corner. And of course, there are some other measures which you will look at. So near respiratory arrest, PFR will be extremely low. He almost surely will be cyanosed. And if the saturation is less than 90, we already discussed that somebody with asthma, that is not acceptable. Somebody with COPD, then that's not that bad a situation. You might be so a profusely sweating patient, asthmatics, when they are in distress, will invariably sit up. They will not lie down. So somebody flat in a supine position, profusely sweating, unable to answer or even answer questions even in monosyllables. Somebody with an altered sensorium, somebody is completely unresponsive. These are the patients who will almost invariably read some kind of resuscitation. So this particular patient that we are talking about was eventually revived, intubated, ambu ventilation was started, and then the patient was, of course, asthmatics are extremely difficult to ventilate in the first few hours because of the severe bronchospasm. Because if you give a conventional tidal volume, say 400 or 450, because we say 8 to 10 ml per kg, great idea to start with in a normal person. But here you have to bring the tidal volumes to maybe even 4 or 6, and that means you are just using maybe 200, 150, 20, 200 cc tidal volume, because the moment you try to push the air in, the air trapping gets worse. You have not relieved the air trapping as yet. There is no enough bronchodilation, so you have to be very careful. Of course, WBC counts must be sent in an hospital situation, and because we are trying to rule out infection, even asthma exacerbations once in a while will be infective. As a rule, they are not. Chest X-ray to rule out a pneumothorax, because once in a while somebody who has worsened suddenly, particularly a non-brittle type of asthma, look for a pneumothorax, because the air trapping sometimes leads to a pneumothorax tendency towards it. Oxygenation between 40 to 60% saturation is somebody. Beta 2 agonist nebulized with a MDI with a spacer. MDI with a spacer is as good as nebulization. So you do not have to nebulize necessarily everybody if you do not have the facility of doing it. Most of the ICUs have both these options available, and both can be done. But if you are transporting somebody, near continuous use of MDI with a spacer, maybe every 5 minutes, every 10 minutes, but 20 minutes is not enough for that person. Give a little more, doesn't matter. Over treating for a little while is no problem. inhaled ipratropium absolutely can be added, and it is considered safe as and when required. A systemic corticosteroid, either a prednisolone or a hydrocortisone or a methylprednisolone, whatever is required, and inhaled corticosteroid should be start as soon as possible. Generally, today we nebulized budesonide, which is one of the safest believed to be there, and up to even 1 gram, 500 milligrams or 1 gram every 6 hourly can be given in the emergency periods. Generally, once you have given a bolus dose and once you have given adequate bronchodilators, the requirement is 0.5, say formoterol budesonide, and 0.5 milligrams of um, uh, uh, 500 micrograms of sorry, for not 1 gram, 1 milligram. So 500 micrograms of budesonide will be enough twice daily as a standard of care dose. Avoid sedation at all costs in asthmatic, come what may. In a COPD, if you take the patient on ventilator and you want to reduce the agitation, you can. But once again, don't use sedation in both these flare-ups as far as possible unless until it is a must. Now, look at this particular X-ray. Is there a pneumothorax? There is no pneumothorax in the same patient. This is nearly 20 years ago. This particular emergency was noted, and was nebulized salbutamol was used practically every hourly, and this is and nebulized ipratropium was added. At that time, they were separate. Today, you can use them in the combination, and this is typically given in 6 hourly dosage, whereas the doses there are there for you to see. So, inhale salbutamol terbutaline usually by nebulization once dose every 20 minutes for the first 1 hour. Oxygenation to achieve oxygenation more than 90%, and in children it should be preferably more than 95%. Get an IV access. Start steroids. 4 milligram per kg of hydrocortisone loading dose, then 100 milligram 6 hourly. Equivalent dose of methylprednisolone are equally acceptable, no problem. Systemic glucocorticoid, if no immediate response, or if the patient is recently taken oral glucocorticoid, or if that episode is very severe, you can go to systemic. I would preferably, if I moved the patient to the hospital, we'll go to systemic because you have an IV access. So once again, sedation is contraindicated in the treatment of the attacks. Don't give a sleeping pill at that point in time. Absolutely contraindicated. We do not need routine antibiotics. I again will emphasize in asthma, but almost 100% of the patients will require antibiotics when they have this COPD exacerbation. They may require an antibiotic like beta-lactam, sometimes macrolide also, because you're thinking of atypicals, and once in a while you might consider giving antivirals also, depending on the situation and scenario, what is this presentation. And of course, I talked about hydration adequately. I would not really start aminophylline. It is started until the end of 1.5 hours, and I'm about to intubate. I might think of using aminophylline as a rescue, but in today's scenario, it is rated extremely low because it is 12 times more toxic. It will invariably will cause more tachycardia. It has important CNS side effects if given in large doses, and therefore, as far as possible, I would not be using IV aminophylline in this kind of a situation. So once again, in the ICU setting also, you may have a good responder, incomplete responder, poor responder, and you will proceed in a moderate episode. Patient will be a good responder, and then hourly nebulized medicines will be continued. Glucocorticosteroids will be given. Continue the treatment for 1 to 3 hours, provided there is an important improvement. In a severe episode, the PFR remains low. Keep on looking at the PFR. It's a very good tool, very simple tool to look at, and somebody who's able to do it, please get it done. Severe symptoms at rest, chest retraction, history of a high risk patient, no improvement after the initial treatment. Inhaled beta agonist with inhaled anticholinergic, oxygen, systemic glucocorticosteroids, subcute, intramuscular, or intravenous beta 2 agonists once in a while, very rarely required, but can consider. And consider intravenous methylxanthines as one of the last resort before putting the patient on ventilator or ventilatory support. If you really ask me, 20 years back, this was a reasonable option. Today, we have almost never used a aminophylline drip in the last 10-15 years because the non-invasive ventilation looks after majority of these patients in a good way, and many of them are not intubated at all. But once in a while, acute severe asthma may require intubation, as I showed you the situations where you must intubate somebody who is profusely sweating, that kind of a scenario. I'll skip through few of these slides because they will be like in a very stable situation, so that doesn't add any value to us at this point in time. And let's move on a little and go towards the, okay, fine. So for ventilating an acute severe asthma, I would not use one of these strategies, and you have to choose BiPAP, pressure support plus PREP early in the year. Can I use it? Volume control initially and gradual to pressure control after 2 hours. Pressure control initially and switch to volume control after 2 hours. Adequate sedation and paralysis after intubation till stability. One of these things I will not do. So most of these thing options are correct, and which is what we should not be doing is cautious CPAP, ideally a BiPAP. Of course, at that time it was CPAP. Today it is BiPAP as a first choice of ventilation, and 6 to 10 respiratory breaths per minute, because these patients have very trapped airways, very trapped lungs, very severely trapped, inflated lungs. So if you give too much of rate, 20, 25, 30 breaths, it is not going to work. Use very low tidal volumes, even lesser than 6. Mostly you will be able to deliver 4 or 6 ml only. I ratio 1:3 or longer, because allow for expiration, maintain a PaO2 of more than 60, and allow the PCO2 to be a little hypercapnic. So even if the PCO2 is little higher, and the pH is, as long as the pH is maintained above 7.2, and you can use adequate sedation and paralysis. So all these are on, that's not a problem. Do not use a volume control as a starting mode unless until you have a very well equipped patient. Now if you really look at this particular patient who was nearly arrested and intubated, her pH was 6.9 at that point in time. And I think, if I'm not wrong, yeah, and the pH became worse after, within first 20 minutes after admission. So it became 6.87. These are nearly incompatible ones, despite okay hemodynamics, good BP, but the pulse rate very high, and this patient required intubation at that time. And uh, after 2 hours of ventilation, after a lot of struggle, our pH had now come to 7.09. We talked of 7.2 as a stable zone, and the carbon dioxide was still very high. This is an extremely high carbon dioxide for an asthmatic, 92. Counter that with a COPD, 90 is not that great. We routinely see 115, 120 also. And these patients often do not require intubation, but this patient did require intubation, no question about it. So pure so PO2 was much better. FiO2 reduction was started. pH was still very grossly acidotic. CO2 retention was still there. Pressure patient was on pressure control. Initially 30 centimeters was used, and the PEEP just 2 centimeters was used in the initial setting. You can use 0 also, because there is no point in using PEEP in these kind of patients unless until it is indicated after a few hours. So this was an acute severe asthma with respiratory failure, low tidal volumes and moderate frequency. Remove the PEEP. In this case, they removed the PEEP completely. Here, this is one thing which additional trick we can do is giving magnesium infusion 4 grams every first 4 hours, over first 8 hours, and then repeat it if necessary. Permissive hypercapnia is a very important word in this situation. Don't try to normalize PCO2. It will not get normalized because there is so much of air trapping, and a small amount of bicarbonates can be given if necessary. This patient, overall GC still looked poor to me after 2 hours, but potentially fully reversible condition. This was my assessment on the rounds after I had seen the patient in the emergency situation. We gave an antibiotic, we gave a clarithromycin, azithromycin there, because these were the two conventional. It could be ceftriaxone, it could be whatever, beta-lactam, that is conventionally sensible in this situation and scenario, which where most of the community acquired infections will be. We did not have a complete documentation of an infection, but we gave it because this patient was extremely bad at that time. CO2 after 6 hours was gradually reducing. Overall intubation, ventilation comfort starts getting better. The volumes go, the chest starts expanding and going back in a normal way. And the pH was still acidotic. And if you really look at what is the pH now, its pH is still 7.0157, but the PCO2 has come down dramatically, 82. So, and no inotropes was required. So it is a good sign in this kind of a situation. So we would not require. So this is the take home message. If you really ask me, this is the best idea. If somebody is doing a peak flow charting, He is regularly 400 in the morning and evening peak flows before taking the inhaler, and suddenly drops to 200, he should go to the doctor immediately. Something which is dramatically dropping 50%, 100% reduction in the PFR. That means treat acute severe asthma attack at least 4 days before it occurs. In fact, that's the dictum, and this is the statement by one of the doyens in respiratory medicine, Thomas Petty. He says treat acute severe asthma at least 4 hours before it occurs. Prevent acute attacks of asthma by taking regular inhaled corticosteroid treatment. In fact, you have to get discussion and a partnership going on with the patient. Keep on talking to him till he becomes a regular inhaled corticosteroid. Somebody gets a near fatal asthma attack, you cannot get away without it. So you have to do that. And I'll before I say thank you, because that slide is the last slide, I'll talk a little about the COPD exacerbation. In a COPD exacerbation, the typical route once they reach the hospitalization is, of course, looking at the oxygenation first, start the nebulization, start the basic process of resuscitation, but at the same time look at the ABG carefully and see whether this PCO2 that you are looking at can be managed by, you don't have to intubate everybody with a COPD. Whereas an asthma with a PCO2 of 90, 95, 100, I'll have to almost certainly intubate because he'll be near death. Whereas in a COPD, often I will get away with non-invasive ventilation as a standard of care. So many people for the first 1 hour, 2 hours will have a PCO2 like this, but it will come up quickly. Now, this particular patient which I showed you, even after 6 hours, the pH was 7.07 and the PCO2 was still about just 80, which started at 100 plus. Whereas in a COPD exacerbation, patient often has a CO2 of 90, but the patient is already conscious. He is not gasping. He's in distress, but he starts getting better within the first 30 to 40 minutes of non-invasive ventilation. It starts getting better. Even if the PCO2 floats a little higher further, 90 goes to 95, I don't have to intubate him. As long as he's looking comfortable, his paradoxical breathing is gone, his air trapping is reducing, more tidal volumes have started going in, then I do not have to intubate that particular patient. So I do not have, very rarely we intubate a COPD exacerbation, whereas acute severe asthma which reaches this kind of a situation, I'm not talking of an acute severe asthma which gets better within 2 days, will not be intubated. But somebody who is supine, diaphoretic, cyanotic, somebody with a saturation of 70, he has to be intubated in good time, because after a cardiac arrest, some amount of damage has occurred before you have actually revived him. So please prevent a cardiac arrest in acute severe asthma. In an acute exacerbation of COPD, the rest of the principles are nearly the same. You will use an anticholinergic bronchodilator. You could use ipratropium for the first day. After beyond the first day, we usually convert them into long-acting LAMA LABAs and long-acting antimuscarinic agents also, anticholinergics also. They don't require every 6 hourly. You can use twice a day, and anticholinergics like glycopyramine also can be used once in a day in a nebulized form. So they can be on nebulizers for 3-4 days. They will invariably require IV antibiotics in a COPD exacerbation, may not require antibiotic at all in an asthma exacerbation, but sometimes out of desperation, like what happened in this situation, we were not sure at that point in time. WBC count was just 11,000, so we gave antibiotics. It's justifiable, but you can be avoiding it if you're sure that this is a young person. The attack has come from asthma alone, and there's no asthma, viral or bacterial or any kind of an exacerbation. It's maybe purely environmental exposure, and that's what is brought in the attack. You need not use antibiotic at all in asthma exacerbation. So I think I have tried to do justice to both these flare-ups, asthma as well as COPD flare-ups, and those flare-ups, how you manage from home right up to the ICU and beyond. And beyond is very important, that patient must be on discharge medications with asthma exacerbation for at least 1 day. So do not discharge somebody who is just was on the last dose of IV efcorlin or whatever that is that you have given 2 minutes ago, and you say, okay, now go home. So please never do that. Make sure you have decided on the lowest possible dose of oral steroids to be given. whatever antibiotic was there, maybe you have converted to the oral, your inhalers are sorted out, your inhaled corticosteroid with long-acting beta agonist is sorted out in asthma, your discharge plan is completely sorted out, and then the patient goes home, is perfectly acceptable. If that is not the story, then please do not do that. And that is the simplest of the messages that I could give you. That again, I'll repeat great Thomas Petty's statement: prevent acute headache asthma by taking regular inhaled steroids and 4 days before the attack happens. Thank you very much for your very kind attention. I hope I have added a little bit to your knowledge. I have added some knowledge to my memories also, what kind of asthma situation I had 20 years back. Thank you very much. And if there are any questions, I'm ready to take them.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice. Sir, we have received some questions, sir. With all your permission, shall we take these questions?
Yes, definitely. No
The
problem.
first question I can see from Dr. Subramaniam. He is asking which
Yeah.
clinical red flag should prompt immediate concern for impending respiratory failure in either condition, sir.
In either conditions, somebody who is supine, I think I'll be no, acute asthma attack, acute COPD attack will make the patient sit up. So supine is the simplest and the easiest. Profusely sweating patient, simplest and the easiest. Pulse oximeter less than 70 or 70 or close to that zone, again simplest and the easiest. It doesn't take more than a few seconds to that is the simplest one. Somebody who has a paradoxical breathing, that means normally with him your stomach should come out. If it is going retracting, that is a sign. Somebody is using accessory muscles, again an ominous sign. So all these put together, then a CO2 retention. In an asthma, as I told you, CO2 retention absolutely an indication for early invasive intubation and ventilation. Whereas in a COPD, that may not be so. That will be the subtle difference between these two, subtle or important difference between these two. And I think I told you one more sign which you can pick up even at home. Somebody with an asthma, no COPD at all, saturation less than 92 on room air is considered to be a grave prognostic sign. So please watch that patient, move him to the hospital even if you think he looks all the way stable, because it is not expected to have that much hypoxia in a person with a normal lung, and we are assuming that the asthmatics have a normal lung in between their attacks. Yeah, I hope that clears your doubt.
Yeah, thank you so much, sir, for sharing your expertise on that question, sir. Moving forward, we have another question, sir. What are the risks of over oxygenation in COPD patients and how to reiterate oxygen safety, sir?
Excellent. It's a very good question, but at the same time, let me tell you one first statement which I'll make is more important. The first statement is people die despite adequate oxygenation, rather than low oxygenation. So if you are in a situation of dilemma, please give a little more. 2 liters is not settling. In a typical COPD scenario, you start with 2 liters per minute, then increase to 3 liters per minute, kind of a thing. So the lowest necessary, but the fear of hypercapnia should not make you not use oxygen. I will be ready with a non-invasive ventilation if the hypercapnia is going through the roof. For example, I admit a COPD patient with an exacerbation. I start him on 4 liters per minute, and after half an hour, I do an ABG and find out that the carbon dioxide has gone up to maybe from 70, it has moved to 90. I'll put the patient on non-invasive ventilation, no problem. For a few hours of non-invasive ventilation, or a day or two of non-invasive ventilation, we will be out. But you say, I will not give oxygen because he is likely to go into CO2 retention, he'll surely die. So please do not withhold oxygen.
Yes,
The best possible oxygenation, despite the best possible oxygenation, also some people will die. So don't blame yourself for starting oxygen. I will blame you for not starting oxygen in good time.
Thank you so much again for sharing your expertise on that question, sir. One last question I will take, sir. The question is,
Yes.
sir, when should we admit or discharge a patient after stabilization, and what are the clinical cutoff or pitfalls?
Yeah, I think I had a little bit of discussion. I'll repeat it because it's beautiful to have a reputation in this kind of a scenario. One important thing is all, both whether asthma or COPD, both patients must be on discharge medications. There is a subtle difference between them, because in a asthma patient, I'm expecting that the patient is on ICS and LABA, formoterol budesonide, 2 pops twice daily, spacer given, all the education given, he's completely all right. He's on a small dose of oral steroids, okay, for next 4 or 5 days, that is going to continue. His antibiotic is about to get finished, I have converted it from IV to oral. All these are acceptable, no problem, that is okay. In a COPD, often you may be on nebulized formoterol budesonide. For example, Foracort is going on, or whatever, whatever that formonide is. Oh, brand names don't matter. So point 0.5 milligrams twice daily of budesonide with formoterol, and maybe for that matter, not ipratropium, titoprium nebulizations nobody uses nowadays, but glycopyrronium is the famous one right now. So if that is going on, it may be continued for a week at home. COPDs often do not become normoxic immediately. Some COPDs who has, say, a bad pneumonia, and he will take maybe a month to recover. In that situation, often you are giving home oxygenation, and many of the COPDs actually are using oxygen at home. So they may go home on oxygen. That's also possible. The most important thing, the last but not the least important thing, is some of the COPD patients, after a recovery, they may require home ventilation also. So we often discharge patients with extremely stabilized patients, have a CO2 which is less than 60, but very steady, very stable. But if I don't give it for 4 hours, they will start worsening. So what we do is we put them on intermittent home ventilation. So they typically use 2 hours in the morning, 2 hours in the afternoon, and the whole night they are using non-invasive ventilation. And this can be continued for a month or a two, or a year or a two, or whatever time it takes. Some patients who have only a pure exacerbation, acute exacerbation, they may not require anything at all, not even oxygen after 1 month. But they may be discharged on both oxygen and non-invasive ventilation, because the muscles are tired, and the fatigued respiratory muscles will tire out after a few hours. So they may not tire out for even 15-20 hours. After 20 hours, the patient starts desaturating again and start retaining carbon dioxide again, get drowsy again. At that time, the non-invasive ventilation and oxygenation, both given together, will do the trick for you. So I hope I have clarified this concept very well.
Yes, again, sir, thank you so much, sir, for answering this question, sir. As I can see, there is no more further questions, sir. With all your permission, shall we conclude this session for today?
Absolutely, absolutely, surely.
And welcome,
Thank
sir.
you
And
very
we
much
would like to see
for
you
having
future
me.
also with different topics, sir. Till then, take care of yourself, sir.
Absolutely,
It was great honor to have you on
absolutely,
our platform. Thank you so much, sir.
absolutely. And many wishes of the World Asthma Day to everybody. Thank you very much, and thanks and
Welcome, sir.
goodbye.
Bye, sir.